In the last episode, we have briefly introduced how the US healthcare system is structured. From this diagram here, you can see how the different groups of society is covered by different kinds of healthcare insurance. And it's very notable here, there is about a 30 million uninsured group, which basically is a very direct demonstration of one of the very prominent and unique problem of US healthcare is the coverage problem. There is about 8 to 10% of their population that are not covered by any kinds of private or public healthcare insurance. So please mentally take a note of this group and some of the other groups, such as the Medicaid group and the employee base, which we will call the private insurance group, because that kind of difference would later on prove to be very, 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 very important in our later discussion. Another prominent problems, I'm saying the word prominent or unique problems a lot because there is a lot of similar kinds of problem across basically healthcare system around the world. There is no such thing as the perfect healthcare system, and they all face similar problems such as scarcity of resources. That might include labor force, capital, funding, and things like that. So I'm pointing out the most prominent and unique problems of the different kind of system, hoping that this would be a better illustration of what some of the specific features or characters of the system could have led to potential consequences of allocation of resources. Okay? For the second problem, I have a little screenshot of the news that might give you an idea. This is kind of out of date, but I think it's a good illustration about a lady who was basically trapped between the gaps of the platform in the Boston Orange Line. She was badly injured, but she refused to call an ambulance because she claimed that she could not pay the bill. This had sparked up a lot of discussion towards the price of healthcare in the US. So price is another big problem, as you can see. And there's different aspects of healthcare which are priced differently, as you definitely know. There are maybe social service, there are service in the hospital, such as operations, drugs, and different kind of things. So it's really difficult to compare. And with that being said, I would discuss in this episode a very straightforward problems about the prices of drugs, as you can see here. Now let's move on a little bit. Okay, down here is I picked out a 2018 study of the average price of insulin per unit of different countries. As you can see, the US is here, which is the most expensive in the world. $99 here we're talking about, if you can see here. And just across the border, Canada, the price is still pretty high, but it's only $12. And the UK over here is only $8. The data on China, it's kind of, I guess, not so accurate, as this is the problem we'll probably bump into very frequently later on, because there is not a lot of research and accurate data of China's healthcare system. So the resource I'm looking at is about 70 Chinese yuan, which is approximately $10. Well, it would fit into here, where Korea, Italy, and a few other countries. So you might think this is crazy, and I'm just bringing up an exceptional case of insulin. But no, the cost of artificial insulin is only about $6. And on average, the US drug prices is about 2.78 times more expensive than other country. Okay. I hope that this example would give you a very well grasp of what the situation is and how astonishing some of the cases are. I guess you're definitely wondering, why is the price of drugs in US so high? After all, the US is an economically very developed country. That was what I was wondering the first when I saw some of these figures. After a lot of research, I can say really a lot of research, I think the reasons can be concluded mainly into three. Let me just write here. First, reasons. The first is about insurance coverage. As we move on, you would see that this is essentially a problem of bargaining powers of different groups of people. As we have said earlier, if you remember the graph clearly, that different parts of the US population are covered by different kind of insurance programs. Some are private insurance, some are public insurance, some are probably covered by both. It turns out that difference is incredibly important to what price of service and drug they receive. And the second problem, not second problem, but the second reason is the intransparency or the lack of regulation, you can say, of system itself. Later on, you would see that these reasons are not independent of each other, rather they are more or less interconnected. And a third reason is about patent. The US patent system, or patent system we're talking about, the patent producers have over the drug they research, their intellectual properties, is also play a huge amount of importance in how the drug is priced in the market, because US has used the free market basically to price the drugs. Okay. So we will first talk about this insurance coverage problem. It turns out the US drug is priced, I guess you can't say 100%, but mostly through the market forces. That is very interesting because that results in how the different, in the problem we just talked about here on, that the different insurance coverage would receive different drug prices. I'll explain to you how this works. For example, let me draw a little house here. For example, this house A is an individual who is one of the 30 million who are uninsured. Let me write uninsured here. Okay. And let me change the color. And this building of people, or I'm referring to group of people, is the producer. I mean, actually, why don't I just roll it into like people, so it's kind of more easy and like vivid, I guess. So, and here, let me assume these are the people who are covered by private insurance. For example, private insurance B, and do I have a different color? Private insurance maybe this is private insurance C, and another color here. Let me actually draw another house. These are like the pillars of the house. Okay, that's a terrible drawing, but never mind, just bear with me. This would be, let's assume, the Medicare group. If you record, these are all people, sorry, just wrote that. These are all the people 65 or older. Okay. Interestingly, there is no government party that is directly involved in negotiating the drug price with the producer. How the drug price normally is determined is, for example, the private insurance company would sign a contract with the producer and they would negotiate price. Let's say this is price B, and another private insurance group would also negotiate with them and they would have a price C. I just write PC here. And then government would involved to negotiate the price of Medicare. That's P Medicare. And as an individual here, individual A, you don't really have the platform or power to negotiate drug prices with the producer, so you definitely get a different price. Price A. It's interesting to know that these prices are not equal to each other. And in fact, the Medicare prices for drugs is usually about about 1.9 to 2.6 times lower than market prices. Market prices, I guess, would be price received PA, or maybe similar to some of the private insured group prices. This is very interesting since the other countries we're talking about in comparison, for example, the UK. Let me draw a different one here. Let's say this is the UK drug producer and all the UK citizens. The market, let's just say the market. The drug price is negotiated by a government-owned institution called the National Institution of Health and Care Excellence. In short, it's NICE. So the NICE run a whole bunch of cost-benefit analysis in order to determine what the suitable price of the drug should be. So everybody in the UK market received the same prices. This is what we call a single payer system, where the reason why it has this is because basically most of the expenditure on drugs are paid by NHS. If you recall, that is the healthcare system in the UK, which is funded by general tax, and it is paying for all the citizens' healthcare. Other countries, such as China, also has a similar institute. It may function slightly differently. For China, it's called National Development and Reform Commission, NDRC. You don't really have to memorize this, but the only thing you really need to know is the market price for any drug is constant and negotiated by government on behalf of all its citizens in the country. Whereas in the US, you have different drug prices negotiated by different parties. So what difference does it make? It seemed like we spent a lot of time explaining not so complicated thing. Well, the difference it really makes is the bargaining power. Let me write it here. Bargaining power. Bargaining power really arises from the number they cover. Well, and parts of the organization they represent itself. So, for example, the Medicaid, you can see, it covers all Americans who are aged 65 or above. So it's a huge amount of population. If we, let me erase this first. Oh gosh, I erased the line too. That's not looking good. Okay, if we go back up here, all the way up here, you can see that is roughly 659 million people. So Medicare itself covers 59 million people. It has a huge amount of bargaining power due to the group it has and the bargaining power of government itself. Whereas private insurance, whether it's A or B, it is only one of the many insurance companies in the market. Therefore, it covers a relatively low, much lower percent of the population. It has a much weaker bargaining power. So if we're going to rate bargaining power here, the Medicaid, the government program, is the strongest, and that leads to the 1.9 to 2.6 times cheaper drugs they have. The private insurance companies has a lower bargaining power. Due to the limited number of clients they have. So they have a more, so they received, or actually their clients receive a more expensive drug. And the worst case is for here. An individual who is not represented by any party in the system. That we are talking about the people who are uninsured. No one would negotiate their price, the drug price that they will receive, on their behalf. And therefore, they have the lowest bargaining power, or I would say it's very little bargaining power they have. And that directly leads to the most expensive drug and service they receive. Okay. I hope this is a clear demonstration about the problems of drug prices arise from different kind of insurance coverage and the lack of regulation in market prices for drugs that basically arise. That arise from the problem of the system. Okay, so that is all about our first reason for the high drug prices. Second reason here is about intransparency or lack of regulation of this whole pricing system. It's actually very much a continuation of the first problem. But before I talk about that, I would have to introduce to you a very unique pricing party in basically this whole process of negotiating the price. So I have to walk you through how usually basically a drug is sold, but we're pretty much limited talking about prescription drugs right now. So usually it's very simple. It's just like most of the other countries. We have a manufacturer, and then, well, this may be a few stages, but let's just call them distributor. And then the drug is distributor or booksellers or wholesalers or however you call them. This may be more than one firms, but let's just for sake of simplicity call them distributors. And then the drug is sold to pharmacy. between pharmacy and any consumer, well, assume this consumer is insured by public or private program. So behind the consumer, there is a insurance company. Okay. There is actually another third party between the pharmacy and the insurance company for the negotiation price. That is a very unique system that only the US has, called PBM, Pharmacy Benefit Manager. It's the third-party administrator of prescription drugs, which negotiate prices for the insurance companies, such as commercial health plans, self-insured employer plans, Medicare Part D plans, and the Federal Employee Health Benefit Program, and some other government programs. So the negotiation of price is not directly taken place between the pharmacy and the insurance. It is the PBM. It's the PBM who actually negotiated the price with the pharmacy, and let's say this is P1, and then theoretically bring that price to the insurance company. So how does the PBM make money? Well, it makes money in two ways. One way is through collecting administrative fees. So basically just, well, a little bit like a real estate agency where they collect the fees for, well, I'm not talking about the same scheme of pricing, but they're not really making money through the product itself. They're through their service. You can look at more or less like it that way. But there are another way how traditionally PBM make money is the price of PBM. Let's say this is P1. Let me just erase this. The PMB traditionally is not by any requirement to disclose that price. So this is P1. I'm going to say this again. There is no point in PBM to disclose this P1 price to the insurance company or to disclose it to the public. In that case, the PBM can actually, let me change the color. So the price the PBM may give the insurance company may be P1 or it can be P2, which is usually a higher price than P1. Sometimes it's the public listed price or the sticker price. Therefore, it is able to make money through the difference in drug prices. So that is also, you can say, another stage in raising up the drug prices. I have a nice little diagram here that shows the share of insulin expenditure, again the insulin example, received by different participants basically in the entire from manufacturer to retail of insulin. As you can see here, where's my pen? Here, the not darkest red but slightly dark red part is the PBM. Its share increased from here 9% all the way to 14% of the total expenditure by insulin. So there's a very clear increase in profit for the PBM in terms of the role they play in determining price and as such. Interestingly, why PBM was there in the first place was actually thought to aggregate the consumer power. collective consumer power in negotiating the price. It's just exactly the bargaining power that we've talked about previously. But it may not, as a self-interested party, fulfill the role that it was first anticipated to fulfill. And a lot of reform has been conducted by the government towards this issue of intransparency. For example, right now, the PBM role in negotiating price for some of the Medicare coverage drugs are required to disclose all of its negotiated prices. So it can no longer basically make money through the difference in prices, at least for some of the public programs. Okay, so now we've talked about two of the reasons. Let's move on to the last one, the patent problem. The patent problem, well, let's start off by talking about what the patent is for. As you all know it, drug research requires a lot of investment. It includes labor power, the scientists, the researchers who are involved in developing a drug, and some other inputs. Well, let's just talk about it in monetary terms. In order to reward the intellectual as well as monetary effort of the pharmaceutical companies and maybe other research institute, the drug that is finally developed is an intellectual property that is protected by patent. That means only the manufacturer or the pharmaceutical company or the institute who researched and developed such drug has the right to manufacture and sell it to retailers or directly to consumer. The process, it doesn't matter, within a given period of time. So in the US, the patent time is usually 20 years. In that 20 years, theoretically, the company has an exclusive right to manufacture and and to sell the drug that they researched and developed. That basically gives them a situation of monopoly, since they are the only producer. They were able to raise up the prices and gain profit. That is, as I've said, a reward of their intellectual and monetary investments. However, after 20 years, the patent expires and other similar pharmaceutical companies, their competitors, are able to manufacture legally the drug, and therefore, since the producer number increases and supply would increase, and therefore we would bring down the price. And since the drug, the chemical they've developed is a very, very, very important source of income to the survival of the pharmaceutical company, they usually start to apply for the patent right even before they get the regulatory approval for their drugs, which means the actual time they get to monopolize the production of such drugs is less than 20 years. So usually this monopoly is less than 20 years. However, many pharmaceutical companies were able to build up what was called a patent thicket around their own products to be able to monopolize the market for even longer in order to gain more revenue, more profit from the drug that they developed. One of the astonishing example is Humira. it is basically an anti-inflammatory drug that is primarily targeted on joint inflammation. The interesting thing about Humira is that it has hit, as we can see here, 200 billion since its 2002 US approval in terms of US dollars. And you can clearly see here, since the approval, its revenues has rocketed sky high. The US government has issued 130, as you can see here, patent for, well, actually, out of the 250 patent that the company has filed. But in the Europe, it has only been granted 6. The more patent it has, meaning that it was able to keep their competitors from manufacturing similar products, because some of these biological drugs are not just like pills, which has, I'm not really an expert on drugs, on pharmacy, but it is more complex and has more unique, distinct feature, chemical structures, or than just a simple pill. So, and also how the dosage, how the way the drug is delivered to the body is also crucial in how it affects. So a lot of the pharmaceutical companies were able to build this patent thicket, what they called, through making small or less relevant changes to the drug itself in order to extend their patent, basically their patent coverage. For example, they can change how the drug is delivered from oral to an injection, just an example, and maybe a slight change in the dosage to reapply or to apply more patent to protect these drugs. For example, in here, Humira, which has a patent about 21 years, and here, it's probably the record-holding drug, Embryo, that is about, 39 years. And this is how the pharmaceutical company who basically researched and developed Embryo was able to build the patent thicket. These are some of the patents it had applied over the course of more than 3 decades, in fact. And the purple ones are, the dark blue ones actually, are some of the most important patents that was allow it to extend and preserve the pricing power over the drug that they developed. Here is, so this is the current cost of Humira in the United States, whereas in other parts of Europe, well, it's important to note that the EU patent for Humira has expired in 2018. So that means the other possible competitors were able to produce similar drugs, as we've said, and lower down the prices. This is a slightly out of date pricing comparison. You can still see in 2017, even before the EU patent has expired, the US price of Humira is still incredibly higher than the other countries. In fact, the revenue of Humira was so much that it actually accounts for roughly 50% of the company's own revenue, that the companies are putting more money, more of its revenues to research other drugs to be able to remove its, well, this is from a business point of view, to remove its dependence over the sales of Humira, because even if they were able to extend the patent, it would have expired at some point. So basically, so far we have walked through this and analyzed the three main reasons why the US drug prices is so high compared to other countries. And now let's talk about some of its merits. And you probably know already, the interesting part is perhaps the merit of the US healthcare system is directly a consequence of the problem it has, or maybe the other way around would also logically be plausible. So just like the pharmaceutical company that developed and manufactured Humira, a lot of the argument has been brought up to say that the reason why there is an incredibly high price for drugs is because that much revenue is poured into the research and development of drugs. Because the entire process of drug development is very, very, very expensive. There's only one way for a pharmaceutical company to collect its revenue. That is for the launch of its successfully developed drugs into the market. They were able to sell it and make profit. However, during its investment stage, it is not only investing into the drugs that were later on going to be developed and launched into markets. A lot of the chemicals and experiments failed, and the drugs did not make it into the market for various reasons. So the drug prices are not only including the successful drugs, but also including the failed ones. And as you can see, US is the largest country by share in terms of health science. Oops. And here, this is also a very nice diagram, just to give you a brief idea in terms of publication, the amount of drug research produced by the US in comparison to other countries. You can see from different platform, basically the US is either the by far largest share of publication and research in terms of health and drug development, or it is close up to be the number one share. So the argument is perfectly plausible, but I just want to give you perhaps a different perspective in terms of how this structures might not necessarily be a cause for, well, might not necessarily be a cause-effect relationship. Same old diagram. The previously shown insulin expenditure distribution. As you can see, at 2014, about 70% of the insulin expenditure goes to the manufacturer. By 2015, it's only 60%. And all the way to 2018, it's only 47%. Just over 4 years. In fact, the manufacturer are receiving an increasingly smaller share of the profit made by the drug, whereas a lot of the profit is actually lost during the process of wholesale and to pharmacy, to healthcare plan, that is the insurance companies, and PBM. So some of the, I guess you can say, self-interested acting parties during participating in the entire process of manufacturing and retailing the drug, getting an increasingly bigger share of the entire revenue. So this is just maybe another side of the story. So that's it about the US healthcare system. To summarize and conclude for today, I guess you can say, well, first of all, the US system is our closest in real life practice example of a private healthcare system. And in this system, healthcare resources are to a very large extent allocated by market forces. It's very, very close to a free market scheme where the prices and how some of the resources are allocated are determined by the multiple participants. In here, we've talked about pharmaceutical companies, distributors, PBM, and insurance companies that all participate in the whole process of allocating resources. And its merit and problems are very much close to the problem of a free market, where there is a lack of regulation that basically results into a big gap between how different groups in terms of their economic and social status participate and receive the distribution of goods and services. The patent provides a very, very good incentive scheme that you can arguably say encouraged the probably world-leading research and production of drugs. That has its very beneficial side, but it also increases the prices that exclude a lot of, I guess you can say, patients who are very much in demand of such a good. I'm talking about drug as a good. They were excluded out of the market or out of consumption. Okay, I think that's enough for today's episode. I hope you enjoyed it and looking forward to see you in the next episode.